Good morning, everyone, and welcome to GLI's COVID-19 Help Resource. We are here today to talk to Dr. Ruth Carrico and hear from the University of Louisville. I personally have been very much looking forward to this webinar because UofL is doing so much to help combat COVID-19, and I'm anxious to hear what Dr. Carrico has to say. No doubt, Dr. Carrico, your team is very busy right now, so thank you so much for taking time to talk with us. I know that you guys are at the front line working every day to help during this pandemic. So before I turn it over to you, I want to give everyone just a brief outline for our discussion today. There is a chat feature at the bottom of your screen, and we will be taking questions through that chat feature. Our team will be trying to cover as many questions as possible during our session today. And then after Dr. Carrico's presentation, I'll come back on and ask those questions. So with that, I'd like to welcome Dr. Carrico.
Thank you very much. I'm going to try to make sure that I get this together so I can switch over to my presentation. So hopefully this is good. Please speak up if you are unable to see my screen. The goal of today, and again, I'm so grateful to have the opportunity to talk with you about what we are doing at the University of Louisville. And I'm here in a room that normally is full of people, but with all of the social distancing, I'm all alone today. So if you hear an echo, it's something that we don't usually hear, but it's just a sign of the times of how we are dealing with
Dr. Carrico, sorry, let me interject. I cannot see your screen. I don't know if I'm the only one or not, but I thought I better just stop now in case you're showing a PowerPoint or something.
Right. I am. Let me get back over and see if
I couldn't see it either, but I was trying to wait till breaking points.
Okay. So let me. How about this? Did I do it right this time?
Yes, now we see.
All right, excellent, excellent. Well, you know, it's a good thing I'm in healthcare and not in technology. So again, thanks for speaking up and letting me know. This is when I was talking with John and the rest of the group earlier today, I said, you know, I've been in healthcare now for more than 45 years. And in infectious diseases, a good portion of my career. And so this has been quite a hot and cold and a positive negative approach, because this is the type of situation that I study for, that I look at, that I've focused on with both research and clinical practice. Now that it's here, and I think, gosh, this should be exciting, but at the same time, it's pretty darn scary. It's scary for all of us, and I know it has caused a tremendous social upheaval, economic upheaval, certainly healthcare upheaval. And so what I want to do today is spend a little bit of time to say, kind of, where are we? What are we currently doing? What is happening in our community? So you can then see the nature of our responses and why we're doing some of the things that we're doing. So I want to spend our few minutes before we go to questions, which I think will be a really important segment, so I don't want to cut anything short. So I'm just going to talk a little bit about the course of this pandemic, what has happened, and what has been going on here in Louisville. Then focus a bit on some best practices for businesses now that, you know, we are beginning to see and understand this disease a little bit more. Then a few minutes on forecasting, and then in order for us to be successful as a community, whether it's a business community or the integrated community that we have, what are some of the needs? So I'm just going to take you on a little stroll with me. And February 4th through the 18th, I was in Morocco. This was where I was. I was up in the tree with the goats. And I was enjoying myself, thinking about, you know, every day I would get on my computer or my phone. I was watching to see what was happening with this outbreak, but I didn't realize the full scope of it. I didn't realize what was actually happening. And I think that was largely because across the world, we just didn't have the information. Now, interestingly, I was invited by the Chinese government to go to Wuhan. I was in Wuhan during the first week of December, and was talking with the government about what our infection control practices are in the United States, our guidelines, and kind of how we manage. I had no idea that this was going on. I was in Wuhan and actually went to the market that was part of the area of interest at that time without even having a clue that this was going on. And this was, they brought together people from the government all across the country to meet in Wuhan to be there for this type of summit, this discussion. So I was oblivious to what was going on. I went on vacation to Morocco. Still, you know, this was somebody else's problem and not a problem in the United States, because we were just beginning to see the numbers being reported coming from China, and then beginning to see the Chinese response, which was in essence shutting down their entire country. So despite the fact that we were seeing reports of 90,000 cases, many of us were saying, wow, this is a pretty dramatic response to 90,000 cases in a country of more than 1 billion people. So as we see now that, that we probably did not understand the complete story, but that was certainly about to change. So as I came back from Morocco, I talked to my boss on February the 17th, and he said, you know, we need to get together first thing in the morning. I know your flight lands at midnight, but we need to get together at 7 in the morning and then talk about what is going to be our response from the university level. Because as you know, our, you know, being a metropolitan research university in what is largely considered the if not the main, but one of the main economic engines for our state, it is critical that the university play a role in understanding and really protecting what is happening in our community when we have something of this nature. So I returned, and this is a timeline of events just so that you have an idea about what was happening here in Louisville with this response. So while I was on vacation, the CDC reached out to the Center for Predictive Medicine here at the University of Louisville. We have one of the 11 regional biosafety labs, and this is one of the labs that's out off Hurstbourne Lane out in the East End. This is a biosafety level 3 lab that works with diseases of primary interest to national security. And so CDC sent the biosafety lab director and the personnel there some samples of the virus, this SARS-CoV-2 virus that is responsible for disease. And we call this is just a point of clarification. The virus itself is this SARS coronavirus 2, meaning it's related to the coronavirus that caused SARS, but just enough different to get its own name. And it causes disease, and the disease itself is COVID-19, the coronavirus infectious disease 19. Just to know the difference, COVID is the disease and this SARS coronavirus is the actual virus itself. But CDC sent the virus to the biosafety lab and asked them to begin to look at what could be done with respect to testing, what about vaccine development, and what about therapies. This is an important point because please remember, this is a virus that we have not seen before. This is a virus that causes disease in humans. Humans have no innate immunity, and it causes significant disease. And we have, therefore, since we haven't seen it before, we have no treatment. So no vaccine, no treatment, and no immunity. This is why we're seeing this global pandemic. So that virus arrived in at the University of Louisville on February the 13th. And then my team got together on the 18th when I got back to begin to say, all right, now what do we do? What is the university's response? What is our responsibility to the community? What do we know? What do we not know? What are our capabilities and so forth? So we began to develop a plan for how we would be able to bring some capacity to primarily public health. So we then worked with the lab, Infectious Diseases Division, our Center of Excellence in Infectious Diseases, worked with the Center for Predictive Medicine, that is the biosafety lab, to think about, all right, how do we develop a test? How will we test our community? Now, this again was important because there is no test, or at that point, there was no test. China had developed a test. Korea had developed a test. Several people had worked on developing their own test. Some worked well, some had a lot of flaws. CDC had worked on developing a test, World Health Organization a test, but we had to look at what could we do here. None of these were commercially available, meaning that we didn't have anything we could buy to start this testing process. So we had to develop our own. We did that with the Biosafety Lab using their equipment. They have some robotic equipment that enables us to test up to 176 people at a time, and it takes about 4 hours to run that test, so we can run anywhere between 700 and 1,000 in a given day. This is critical because the commercial labs are offering the ability to run 5 tests at a time, and you get your results back in 2 weeks. We would have the ability to run 700 a day, and you get your results back within 24 hours. So this was a massive capability that Louisville is one of the few places to have this capability. Then we began to look at, all right, if we can test, how would we develop a process where we would obtain the samples from across the community? How could we test? How could we make sure we had a process that was error-proof? So we began to bring in our industrial engineers to help us understand that we know they help UPS and Amazon deliver packages and make sure the right package gets to the right address. So we know that industrial engineers are critical for us in knowing what our process needs to be. So March 2nd, we began testing a simulation of a process to both receive samples, do testing, and get results out to all of the groups, public health, the individual caregivers, the hospitals or organizations, who all needs to know the results and how do we get them. Then we actually provided a first test on about March the 10th was our first testing performance, and then we perfected that process over the course of the next couple of days. As a new test, we had to also verify and get the approval of the state to say that we know what we're doing, so they had to validate our test results. And we started and actually achieved that on March the 13th. At this time, the only thing that we were doing in hospitals were if they identified a patient or had somebody they thought might have COVID-19, they were isolating them, but we had no other way to manage this. If the person exhibited symptoms and we recognized it as COVID-19, they would be isolated. But we quickly realized that this was going to be a challenge because people are infected but without symptoms. This has challenged all of us, and this is why we've seen disease rampant, and really why we are seeing some of the situations such as in New York, where you'll have people that are positive but they don't know it, yet they are able to infect those around them. By the end of the day, on March 13th, we were working with 10 hospitals. We had tested 120 tests, and 5 of those were positive. At that point, we began to see, now that we've got 5 positive cases, telling people in the community that we do have disease in Louisville, we began to address some concerns from the healthcare providers that they don't have enough masks and gowns and respirators and so forth to be able to address a surge or increasing numbers. So we began to work with hospitals to let them know what we were seeing, where we were seeing cases, if there were anything uniform or identifiable about these cases. So for example, were they all at the same party? Are they all part of the same family? Those sort of what we think as epidemiologic links or case links. And then we were at the same time working with the health department. A week later, we had increased to, and we're including 2 hospitals in southern Indiana because of the movement across the river, that when we think about Louisville, it's really the Louisville or Kentuckiana area. So within a week, we were working with 12 hospitals. We had run 730 tests, and we had identified 34 positive. Now, keep in mind, when you identify 1 positive, there are at least 10 more that you have not identified. So we knew that we were rapidly seeing increases in our community. We were providing this information to the state. I think we kind of took the state in some terms by surprise because our capacity really exceeds what our state lab could do at that point. So I think they're like, where are these tests coming from? And because we are required to report these we were kind of surprising people, showing what capability exists at the university and within Louisville. At this time, we also, in these positives, identified a healthcare worker that was infected, that we think that they were infected as part of their healthcare activity, but we don't know that for sure. But we were having to look at, was transmission occurring in the healthcare setting, and could this healthcare worker have acquired this infection from an unrecognized patient? So we began to work then more diligently in saying, what information can we gather, and how should we continue to expand our approach? A week later, we had added another hospital right outside of the Louisville area. We had also begun to look at long-term care because of the outbreak that we had seen in Washington State that impacted an entire long-term care facility. These elderly people are at incredible risk. We saw the number of deaths. We knew then that we were seeing patients being transferred from long-term care into the hospital setting. So we needed to expand then our approach and include, at least let long-term care facilities know that we have the capability to test. So within that week, we more than doubled the number of tests that we had done, and we quadrupled the number of positives. So we clearly are seeing more cases in the community. We're seeing additional transmission. And at this point, we began working even more closely with the hospitals. Now, keep in mind, every day while we've been doing testing, we are working with the chief medical officer of each hospital so we can let them know what is happening across the community, because these hospitals all belong to different organizations, different groups, typically do not work that closely together, although they do work very well together. This is not the type of information that is generally shared. So we were kind of the knowledge node connecting these hospitals, and we suggested that hospitals take the approach of universal masking. What this means is that every person entering a healthcare facility, we recommended that they start wearing a mask, all healthcare workers, because we know that there are some individuals who are infected but not yet ill. Therefore, they may go to work thinking everything is fine. They may feel fine, yet they are able to infect others. So now we want everybody wearing a mask in a healthcare facility, not only to protect them from acquiring the infection from a patient or from others, but to protect others from them in the event that they are infected. Now, we know this disease. I know that everybody is watching TV and reading about it, but this is a disease that is primarily transmitted via the respiratory route. So that means I exhale. If I'm infected, I exhale or I cough. Then I project these little particles into the air. It can be deposited directly into your face, on your eyes, your nose, your mouth. You then have the opportunity to become infected, or I cough and these particles land on surfaces that you touch, and then you rub your eyes or your nose. That is how transmission can then occur from the environment. We are also learning that there is probably transmission from potentially other body fluids as well. So the opportunity to become infected then is, as we are learning more, we are learning how clever and relentless and sneaky this virus is. And so if we're going to win this war, we're going to have to be relentless in our approach to addressing it. So a week or so later, by April 9th, as of yesterday, we were working with 14 hospitals, 10 long-term care facilities. These were numbers from early yesterday morning. Now we're at over 3,000 tests that have been done, and we have about 440 individuals who we have tested and found to be positive. So you can see our proportion of testing that are positive continues to increase. We are recognizing long-term care as kind of our next frontier, that they're being called hotspots because testing has not been available. A lot of personal care is provided to individuals in long-term care, and we have patients that are incredibly at risk. So this kind of gives you the overview of what we have done just in the last really seven weeks. We think that things move quickly. This has been at a lightning speed in coming up with what can we do to actually getting things in full swing. We have done this primarily because at the University of Louisville, we have a solid infrastructure that we have worked in with the community with respect to clinical research for the last 15, almost 20 years. Recently, we were recognized by Pfizer Pharmaceuticals as the North American Site of Excellence, the first in the world and the first in the United States that will be working with the pharmaceutical companies as they try to develop vaccines. So, of course, Pfizer is very interested in the work and development of a vaccine for this virus because we don't know what to expect from the virus. And I'll talk about some of the challenges in a moment. But our research structure has enabled us then to pull in the individuals necessary to look at how we're going to deal with data, how are we going to implement a process, what is the laboratory responsibility, which of these specimens do we need to freeze for further study. That's part of our biorepository. We have a quality assurance unit to make sure that we are accurate and correct and error-free. We have a biostatistics unit that helps us understand the data, turn the information we are getting into interpretable data, and then how do we share that? And then we have a medical writing unit that is responsible for writing putting our findings into publication, because that's how people all over the world are working. In fact, we're working quite heavily with people in the Southern Hemisphere, specifically in South America, because we're looking at the movement of this virus. It will probably follow a very similar pathway of influenza, that the Southern Hemisphere is not heavily impacted at this point, but we anticipate that it will be there within the next few months. So they are trying to learn from what we are doing so they can then do the things that have been successful and avoid the things that have not been successful. We have a number of opportunities. One of the things that we have in our educational support, we have 2 peer-reviewed journals. So we have the ability then to publish, to get this out into the literature so it is readily accessible and viewed as credible to the rest of the world scientific community. And then we work a lot on marketing, getting our information out, and then doing both internal university outreach, which some will call university inreach, and then community outreach to make sure that groups know what we are capable of, and then know what we can do, and then help us figure out how we can help. Through it all, then we have to always be looking at the finances and make sure that we have then administrative approaches. So it's almost like within our Center of Excellence for Research in Infectious Diseases, that's the CERID abbreviation, we have to make sure that we are operating almost like a little biotech company locally. Louisville is of interest, just as an aside note, Louisville is of interest to the medical community worldwide because our census characteristics show that the population in Louisville, the population of Louisville, is really a little microcosm of the United States. So when we look at disease incidence in Louisville, you can just multiply it up and say this is the disease incidence of the US, because the age, the ethnicity, gender, socioeconomics, education, and so forth of Louisville are representative of the US. Now, the same can't be said for Kentucky. Kentucky population is not representative of the US, but Louisville population is. So when we look at what we are doing and disease and impact and so forth, we are of great interest to the business community simply because what we bring. Now, we're also of interest to the business community because one of our major areas of business is healthcare. So when we think about how this disease is impacting the healthcare infrastructure, that lets you know why our focus has been on maintaining the safety and the integrity of the hospitals and long-term care, protecting healthcare workers, both through testing as well as appropriate use, good stewardship of personal protective equipment, So everything that we have done has been focused on how do we maintain a healthcare infrastructure? Because if you get sick, your family gets sick, you have to go to the hospital, you deteriorate, your condition deteriorates, and you need mechanical ventilation. Trust me, you want a nurse there to take care of you. And so our focus has been on making sure that nurses feel safe, that they know that we are watching how they are doing, and that they can go to work with some sense of security. This is our team. This is before we put the social distancing. This was as we began to get started in the end of February. Nobody gets together like this anymore. Everybody is either masked or 6 feet apart, or in most situations both. But this just shows then the scope of the team that we have involved. This is our operations center, where we are in the clinical translational research building on Hancock Street, so that we have our coordinating center where we have then our main team that is together looking at our results, looking at what is happening, who then are those that we need to communicate with, and then make sure we have a central site for operational concerns. This is the robotics machine that we have that's causing all the interest, that they have the ability to do this great thing. Instead of doing what our usual hospital-based test instruments do, which means I can test 6, 12, 24 at a time, this can test 176 at a time, so the capacity is tremendous. We have our research team. Again, our clinical lab for infectious diseases has done the validation. We had to make sure that our process through this research arm using the biosafety lab, we had to make sure that the results were valid. So we did parallel testing using the resources we have in our own research lab and our clinical lab to make sure that results that we were giving were were both accurate and of the highest quality. So that's the boss on the left, Julio Ramirez, that's pretty much the brains behind this entire outfit, and is an incredibly visionary leader. I want to just show you, this is a graph that the Biostats group just sent me real quickly so I could keep an eye on our cumulative percentage of positive tests. You can see when we first started over at the far left on the 10th of March, as we began to get our operations up, how clearly this graph is rising. Now the dotted lines, for those of you that are statistics buffs, that's our confidence interval. So the big thing to focus on is the dark line in the middle that shows our number of tests are increasing each day, and that's again what we are continuing to find. We know from all of the research that if we don't find the positive tests, the individuals that are infectious, we cannot get in front of this. So it is critical that we continue testing operations, that we be able to look at these high consequence settings. Now, if we had enough tests, and I think there was an editorial in the newspaper last week that said we need to test everybody. I don't think anybody would disagree with that. The problem is we don't have the ability to test everybody. We don't have the number of test kits available to do that. We are extremely limited. Many of our supplies now are being diverted to New York and other areas of the country where they are having a tremendous problem. We are trying to be smart about our testing and say, it's kind of like somebody asked asked before, this bank robber, why'd you rob the bank? He said, well, that's where the money is. That's our approach too. Why are we going to be testing in healthcare facilities? Well, that's where the patients go. So we're looking to see who actually has the disease, understand the characteristics, and then use our public health partners to find the others that may be infected that are related to those cases. So we've got to look at the right places. So we have to be using our resources wisely. Now, the challenges with COVID-19, again, everybody breathes, and this is a disease that is transmitted via respiration. So it's not until people stop breathing that our risk goes away. We are also seeing significant disease in patients who are not presenting with respiratory symptoms. And this is one thing that we are learning about the clever nature of this virus. We are seeing people present with other symptoms such as diarrhea. That's not something that we usually look at when we are thinking about a respiratory disease. We are seeing people that don't have any symptoms at all that are still able to transmit the illness. They may never show symptoms. So therefore, we know that there's probably some type of chronic carrier state. This is why the public health now is recommending, and you probably heard the governor say, when you go out in public, try to wear some type of respiratory protection. Please don't use the traditional masks that healthcare workers use. These are designed to have a little bit of fluid resistance, and if they are up in the face of patients, they cannot wear a homemade mask. If you are going to Kroger, you can wear a homemade mask, because we know you're not going to have that up and close and personal communication, or at least you shouldn't be, with someone else. But healthcare workers have to, in order to provide the care that is necessary, the patient care that's necessary. So we ask people not wear medical grade masks in public. If you want to wear a mask, wear something that is homemade instead, so we can keep these rapidly dwindling supplies available for healthcare workers. Again, if they get sick, they can't go to work. If they feel unsafe, they won't go to work. So we have got to provide protective equipment. We know that we see a very distinct course of illness with this disease. You may become sick and you may run a fever and feel terrible for 7 to 10 days. Some people are going to get better after that. Some people may start to get better and then immediately develop viral pneumonia. These are the people that have to be hospitalized, that we will see require mechanical ventilation. We are seeing disease also in segments of the population that we typically don't see impacted by viral illness. We're seeing significant disease in this 30 to 50-year-old population. It is heartbreaking to see a 30-year-old that is in excellent health become so sick they have to be on a respirator. This should not happen. And while this is happening, that means we need to work harder in our efforts to identify where disease is happening and try to do what we can to contain that. We're seeing respiratory failure and need for ventilators, the mechanical ventilators. We're seeing healthcare workers exposed. We're seeing healthcare worker disease. And all of this is happening while we have no vaccine yet available. We have very few treatment options. There's a lot in the literature about some oral medications they are fraught currently with problems. They may work for some. That certainly is not the only answer. And we still need to do significant work in treatment. And then we have very little data regarding what happens after you become sick. Does that mean you are immune? Well, we thought, that there should be some level of immunity, but we don't know how durable that immunity is. We're starting to get data from Korea where they had individuals that tested positive, recovered, and now have been re-exposed and reinfected. So this is looking more like influenza in terms of the repeat illness that is happening. We don't know the impact of disease. In some diseases, the second course you get is milder disease. In others, the second course you get is more severe. We don't know that. We don't have enough data to make these decisions. This is why we need to continue to study this. The challenges, I think, for the business community are those that are in the general community, and that is, how do you run a business when you have to retain that social distance? We've had these fear-ignited buying patterns. There's no, for some reason, when you get a respiratory illness, everybody buys toilet paper. You can't find that in any place. I've seen some of the comics on Facebook that now, instead of Easter eggs in your Easter basket, you're going to give people rolls of toilet paper. That sounds funny, but boy, it's certainly hard to come by some of these items. I went to Kroger a week or so ago, and Kroger had two doors, the one that I go to, the one that's near the paper aisle and the one that's near the produce. Nobody was going to buy carrots, but everybody was going in the other door. So that made it real easy for me to sneak in the side, grab a few things, and then get out and not come in contact with anybody. So these buying patterns are taking everybody by surprise. It's interrupted business continuity and certainly impacted the general economy with a downturn, and we've had a number of business closures, layoffs, furloughs, reductions in in staff and hours. Now we're at the point where we have only essential businesses are operational, and I think many of us are expecting at any time that we will have a much more strict community lockdown, because as we see these numbers of cases go up, the only way that we can stop transmission is to limit the movement of our population. So if we have groups that still continue to get together and travel together in close packs, we are still going to see transmission. And because, again, we can have people that are infected and don't know it, don't exhibit symptoms, this is a huge problem for us if we are going to stop this. So let's think then in our last closing few minutes before we go to questions, what are some best practices? Well, I think we all know that as many businesses have developed their pandemic influenza plan, many of the elements in that plan are what we are doing now. And that is, we're trying to figure out what aspect of our business can be virtual, what can be done remotely. Fortunately, many businesses can have some aspect remotely. Others, very sadly, this is a stab in the heart to their business. But we cannot allow then the gathering of individuals in any setting where that may become then a new place for this disease to grab hold and then have another place to roar through our community. We also have to have infection control practices firmly embedded into every business. That means the ability for people to separate themselves. We need to know what it means to perform environmental disinfection. What are the things that we need to wipe off, and what types of products, whether they are traditional germicides, the quaternary ammoniums, or learning how to make a bleach solution, a 10% bleach solution, which is 1 part bleach, 9 parts water. I always tell people when you're going to make that, use Clorox if you can. It provides you a more consistent formulation than discount bleaches, but use what you have. People are developing and using hydrogen peroxide, diluted hydrogen peroxide, and diluted vinegar also to make environmental disinfectants. Making what you can to reduce the virus that may be on surfaces, because that virus may persist for days on a surface. Making sure people understand the basics of hand hygiene. Soap and water hand wash when you can. Other times use an alcohol-based hand rub. Products that are non-alcohol based, we do not have effectiveness data for those, so we want to stay with what is tried and true. Soap and water hand wash or alcohol-based hand rubs. We need to make sure there is some process for knowing when our employees are sick and being able to monitor that, and then reacting to what our employees are telling us. If we have employees that are ill, that are demonstrating symptoms, clearly they do not need to come into any public area. They need to be told, stay at home, stay away from others. If you have employees that are out, they should be wearing some type of a respiratory protection, not only to protect them from others, but remembering they may be one of those asymptomatic carriers. And then we need to figure out how to manage the ill workforce, that we can't have people that say, okay, I feel better, now I want to come back to work. No, in healthcare, a healthcare worker cannot return to work after they've been diagnosed with COVID-19 until they have been cultured twice and had 2 negative cultures. Well, if we don't have the way to test them, we will never get those 2 negative cultures and never know when they are safely able to come back. So I kind of circle this all back around to the importance of the work that we are doing with testing. Now, as with all situations, there is opportunity for innovation, and we've had quite a amount of innovation in the community. The Speed School of Engineering at UofL and the students there developed face shields and are mass producing those using 3D printer technology as well. I think Ford is also doing this. Other groups are now doing this, because if a healthcare worker does not have a mask to wear, they have to wear the same one all day. Using a face shield may protect the integrity of that mask so they can safely do that. So face shields have been critical. The Kentucky Nurses Association has been very instrumental in getting face shields out to nurses so that they have them for themselves. They don't have to rely on anybody else. They have their own face shield along with information about how to appropriately disinfect. On the right, you can see some 3D printing that has been, the technology has been used to help us 3D print the swabs that we need to use. If we're doing a nasal swab, we have to have a little swab then that I can put in your nose to test you. Unfortunately, in the United States, this is in extremely short supply. So we are having then our engineers help us develop a swab that we can use. It's a little resin swab that's very soft, but does its job. And so if we can't get the swabs purchase those from any manufacturer, nobody expected that we would need 320 million swabs for the United States population. So the quantities that are needed are either not produced in the United States, or we don't have the capacity to produce the amount that we need. We've learned with this pandemic that we have incredible reliance on products that are manufactured outside the US. If the countries are not willing to release them, so for example, China makes a lot of personal protective equipment. None of that was getting out of China while they were dealing with the early stages of this pandemic, and still we are not getting those items that we need. So that means that we're having to relook at our business practices in the US and rethink then our reliance upon external sources of life-saving or critical pieces of equipment. So I'm sure that this is going to be a new area for business. People ask all the time, well, so what's going to happen? Well, and I tell them, if I had a Ouija board, I would consult my Ouija board, because that would probably give me just as reliable information as any of the experts now that I'm seeing on TV. Some things that we know is that with any type of illness, we will continue to see illness until there is some threshold of immunity that is reached. We don't know what that is. For influenza, in most diseases, we have to see 80 or 90% of the people infected and immune before we consider this to be a safe level of disease. We're also looking to see what is happening and what will happen in the Southern Hemisphere, because we expect disease in the Northern Hemisphere to move south. Then will this disease move north again, kind of following that influenza pattern of returning in the fall? If it does return in the fall, how do we deal with it? What happens if it continues throughout the summer and we never get a break? We clearly are going to need to have emphasis on treatment and vaccine development. We also need to develop tests for immunity. Now, we all see the little test, I think, that you can buy in your home and check your level of immunity. Well, that may tell you if you have antibody development, but it doesn't tell you if those antibodies work. And it's important to know, our bodies are amazing machines for producing immunity and immune cells. But sometimes because of the clever nature of the virus, they can't be effective. A great example is HIV. The test that we use for HIV tests for presence of the antibody, but you're not immune to HIV. So this is the production of antibodies that are not effective. So that at-home test doesn't really tell you whether or not you are immune to the disease. It may tell you if you have had it, but we also don't know how accurate those results are. We also know that there's some risk of reinfection. So we need to be prepared for that. And we also now are working with people who have been infected, because we think if we can have them donate blood, that maybe they will have some antibody that may provide either prompt their body to recognize this as foreign and begin to produce temporary antibodies that may protect them. So we are then eager to find people who have been infected, so we can say, hey, now that you're better, would you consider donating blood? Because if I can transfuse your blood into someone who is seriously ill, that might save their life. This becomes important if you think about this as a personal issue. Any one of us can become sick. So it is critical that whatever we're doing in our community, that we look at it on a personal level. This is going to help me. It's going to help my children, my grandchildren. So making it personal is important. We are supporting vaccine trials to try to see, can we look at how a vaccine is being produced, because all of this we know is going to change how healthcare is delivered. That our society, our healthcare, after we see this wave, is going to be changed forever on how we approach all aspects of what we do. Now, I want to close just at the end with, well, what do we need? I can never talk to any group without saying, I need you to understand the investment that is required in these responses so we can continue this work. We need an investment in clinical research so we can understand the disease. We can continue testing. We need to understand what interventions work and how we prevent disease. We need to be thinking about how will we deal with mass vaccination. If the vaccine is available, how will we get it into all of our citizens? And then what innovation opportunities need to be supported. None of this happens free. At the University of Louisville, the President Bendapudi gave us $500,000 to get started with this research. We have just about burned through that in just purchasing of the materials that are needed for testing. If we run out of money, we will have to stop testing. That means we will not be able to see what is happening in our community, and this will impact us all. So we are just desperately searching for avenues to access the funds to keep this operation going. We're going to have to learn how this disease is going to change our social interactions, and then what does this mean to individuals with chronic conditions? How are we going to make sure that people with diabetes can still receive care? How about somebody that is having a myocardial infarction or heart attack? How do we make sure that they can receive care in a way that is safe for them in the time of this pandemic? So tremendous needs just within the healthcare aspect of this situation. And I just want to close just as a reminder, this just happens to be pictures of my family. And this is a personal disease to me because any of my family can be infected. My son's pet, we're learning that animals can be infected and they can also harbor the illness. So every aspect of our personal lives is important in understanding this disease. And if each one of us wants to come out on the other side of this in some sort of healthful condition, then each one of us are going to have to figure out what role do we play in improving our ability to manage this disease. As I said, this infection is clever, it is fearless, it is relentless. And if we're going to win this battle, and clearly this is really more than a battle, this is all out war. If we are going to win, then we're going to have to be just as fierce and just as relentless in our approaches, or else we can expect to be infected and we can expect then to just with some level of resignation be willing to accept the consequences. I'm not willing to do that. We are giving everything that we have at the university to protect our community. We need then the help of our community to make this continue. So I'll close with this, and then let me quick look and see. Oh, I've been at the pulpit at the Church of COVID-19 for a little bit longer than I wanted. So I want to stop and make sure then that I can address questions that you may have. So let me turn it back over to you guys.
Thank you, Dr. Carrico. That was really a fascinating presentation, truly. You talked about the need for more funding to do research. Are there ways that GLI, the business community, your average citizen can help advocate for that research? Is there a bill that's going to be going through that we could contact our legislators about?
You know, I really don't know the answer. You know, we have heard a lot about millions and billions of dollars that are available for this effort. We have not seen any of that. Every day we're asked to, please, can you help with this group or with that group? And we're not going to say no until until we exhaust our last penny and are just flat on the floor. We have, my team under Dr. Ramirez's direction, we have been in the office every day since February the 18th. Every one of us. Nobody has had any time off. I'm in isolation from my family because I'm down here in the middle of the response, and so I can't see my grandkids. I can't see anybody just because of this event. So it is a very personal thing. So we are on the lookout every day for money. We have not seen anything materialize yet. Other than what the president provided for us. So we have to get serious about finding this, or else we will have to stop operation. If we do that, we will have no ability to see what is happening in our community, and very limited ability to respond. So this truly is an emergent condition. So we would love help from anybody that help direct us, give us new ideas and new approaches for how we can achieve any level of funding. It costs us, just to let people know, it costs us about $100 per test.
That's great information. And let me just say thank you for all that you're doing. I know this cannot be easy for you personally or for your team. And we owe you a great deal of thanks from everyone in this community and everyone in the Commonwealth for that matter. So I think you've probably heard that we formed a task force of business leaders. And I think that one function of that task force can be advocacy in this area for more funding for your purpose.
Yeah.
With PPE, for instance, we've been able to work with a number of businesses in the area who can manufacture PPE. Can businesses in our community manufacture the test swabs or the nasal testing kits that you mentioned? Is that something we could work on?
Yeah, so I think that we're getting these new prototypes of it's a really weird type of product. It has to be made of a certain type of material, or like it can't have any wood in it. It can't have any cotton in it. That interferes with the test. It needs to be able to actually grab the virus as we do that nasal swab and then release it into the media that is used to start the growth of the organism so we can test it. So it has very precise specifications, and it's taken quite a while to figure out how to actually develop that, how to make sure it's made of a product that can be sterilized, because if it's going to go in part of that testing process, it has to be something that is already without contamination, so we can actually see what we're looking at from the laboratory perspective. So that has been a huge challenge in those just those little things that you think, wow, it's a little nasal swab that's creating a problem. Oh my gosh, it's a microscopic virus that's creating a problem. It just makes us confront all of our traditional ways of thinking and approach. But I think businesses have done great, and where they have looked to see who has gloves that they are not using, who has something that can be used as a protective gown, who has a mask or has respirators. We've had great support in the healthcare community from the hardware stores and others who will say, oh my gosh, we've got that. It may not be perfect, but it will be helpful for what you need. So we've had a lot of outreach from communities that are helping us with supplies, and believe me that when you hear the cheers of the nurses when finally they realize that they're going to have a mask to wear for their shift, it's amazing, because without the care and I'll tell people, nurses are the only profession that will touch every single person sometime in their life. No other profession. So we have got to support and be right behind, right there for our nurses so that they can safely care. Because unfortunately we're seeing deaths in nurses and in our physicians in other states and countries as part of this response. We do not want to see a nurse die in the Louisville community.
You're absolutely right about that. Can you tell us, in terms of testing comparison, how much are we testing in comparison to other states? And in terms of the number of deaths per test, do you know the figures on that?
I wouldn't have the number of deaths per test. I could probably do the math, but right now we know that every healthcare facility, every place is using any resource that they can for testing. That the commercial labs like Quest and LabCorp have the ability to do the test, but they are providing service for the entire United States. And the turnaround time is not as quick as we need. We need a test where we can get the test results quickly. In Louisville, we're one of the few cities that has the opportunity to get these test results back quickly. And this is why we're making this available not only in Louisville, but outside Louisville, because we're part of the Commonwealth. So if we have capability, we need to recognize that as one of our former health commissioners said, there's no such thing as a leak on your side of the canoe. So if we look at this as being something that we're working on together, then we have to have a strategy that is inclusive and not exclusive. And so although our experience has come from dealing with what is happening in Louisville. This is not an exclusive process at all. The only exclusion that will occur is when we have no more money to run the test, because we can't purchase the reagents that we have to run the test.
Can you tell us how accurate the tests are? I mean, I've seen numbers on Facebook that say it's like 60% effective, but Facebook isn't always the best place to get news. So can you tell us what your impression is?
Well, the testing methodology that we use is incredibly accurate. It is very sensitive and very specific. The key is, in order for me to get a good test result, I have to provide a good specimen. And I have to provide the specimen at the right time in that patient's course of illness. So one thing that we're learning that is quite interesting, that another very clever thing about this virus is it will live in your upper respiratory tract for maybe the first 5 or 6 days of illness. After that, it moves then into your lower respiratory tract. So I may do a nasal swab test, but I can no longer find it, but you are indeed infected. So that's why, as a healthcare provider, I need to have expertise in what type of specimen to obtain, when to obtain it, and then making sure it's a good specimen. So as we are learning this, we are getting this information out to our healthcare community so we can let them know, hey, how long has this person been sick? Well, you may not want to do a nasal swab. You may want to try to get something from their lower respiratory tract instead. So helping us then do adequate diagnosis, because you are entirely right. If I give somebody a negative result, that says, oh, good, I can take them out of isolation. I can let them go about and come back to work. That may not be true. So, you still have to evaluate the results of that test within the context of that person's illness presentation to know what should I actually be doing. So that means it's important that you have somebody that has some expertise in this area working with you hip to hip.
Absolutely. And in terms of the patients, you said 30 to 50, you're seeing an increase in that age group. Why do you think that is?
We don't know. We don't know why this is happening. We don't have enough information to know if there are clinical characteristics. So it'd be easy to say, okay, if you're a smoker, you've already damaged your lungs. We know smoking changes the architecture of your lungs, that you are at greater risk. Well, we know that's true. You're at greater risk for anything involving your lungs, but we don't know if that is why this is occurring in that younger population. This is one of the things that we have got to understand better. Why is it that the rate of illness in this young population is not that much lower than the rate in the older adult population? That shouldn't happen. Usually we see infection and the highest rates of serious illness and death in the very old and the very young. Well, we're seeing very little mortality, serious illness in children. Even though we know children become infected, we're not seeing deaths at the rate that we usually see with viral illnesses in children. So that's a great point. I'm thrilled to that. As a grandmother of 2, I'm thrilled to death that the children are somewhat protected in some way from this virus. But on the other hand, I'm not. I'm in that group where I'm at risk. If I become sick, then, I've got maybe a 20% chance of needing a ventilator. And once I'm on a ventilator, then it's like 50-50 whether or not I'll be able to survive. So it becomes, it's taken on new meaning for all of us when we make it personal.
Absolutely. You mentioned animals as well, and animals can get this, they can carry this. What sorts of signs should we be looking for in our pets?
Yeah, from what we know so far, and again, we have very little data, at least very little data that I'm aware of. What I do what I think I know from the data that are out is that the animals don't become sick. There's a lot of work that's going on now in the UofL's Regional Biosafety Lab that they do a lot of research with ferrets, because ferrets, interestingly, have lungs like humans. They tend to get disease and it impacts their respiratory tract just like humans. So a lot of our research with animals is done with ferrets, and ferrets are not getting sick. They have the virus, but it's not impacting them like humans. So this is really making us scratch our heads, because everything we thought we knew about infectious diseases is kind of upside down. We are having to rethink a lot of our what we thought were the truths about illness. This disease is challenging every aspect of testing, diagnosis, clinical outcomes, and how we approach it.
Can you talk about some of the claims that if you take certain vitamins or herbal supplements, you'll be kind of prevented? Do you have any recommendations for things people can take, or are these statements accurate?
I don't know that they're inaccurate, but I think there is absolutely no evidence that it is accurate. I think, as with any disease, if you can maintain good general nutrition, if you can keep your blood sugar under control, if you can limit then the cardiac effects of what you eat and what you drink, if you can get plenty of rest, if you can do all those things, that we know that enhances your immune system in general. But I don't think there are any data that says if you eat more of this fruit or if you eat more of that vegetable, or that we have any data at all with any of the complementary medicine. I can't say that it won't help, but I don't have any evidence that it does.
Got it. Well, this has been a very informative presentation. It truly has. Just during this presentation, we've been texting back and forth as a team saying, this is really great, and we got to send this recording around. So we have been recording this today. We are going to send this out in our email blast that goes out to all of our members, and we're really trying to get businesses aware of everything that can be helpful right now, and more knowledge about this virus is certainly helpful. Like I said, we know you're on the front lines of this. We thank you for all that you're doing, and we really appreciate your time today, Dr. Carrico.
Thanks. Well, it takes a team, and we have a marketing and communications team that is trying to help. How do we provide information that just resonates with different groups? I leave my email address up there. If you can think of ways that we can continue to expand in that type of information, we want to do that, because again, this needs to be important to all of us. We just have to figure out how do we get the best outcomes. We do that by doing the best type of outreach so people understand what we need and what we are asking for. So it's my hope that at the end of this, that there will be a greater understanding about the serious nature of this outbreak and the needs that we have in our community to keep this work going at a time when everybody is making sacrifices. I don't know anyone that is not impacted negatively in some way by this. So we are asking a lot for any type of support, but without it, we can't continue any work. So I thank you for the opportunity.
Well said, thank you. Well, for everyone else, thank you for joining us, and we are going to be sending you an event survey later today. Please give us your comments. Please join us. We have another session on April 14th from 9:30 to 10:30, and the topic will be small business cybersecurity. I think we've all seen a lot of emails out there about different products, and this is going to be all about which things are safe and how to keep your system safe during this crisis. We are trying to provide you with as much information as possible as we get through this together. If we can ever be of assistance, if you ever think of anything we can do that we're not doing or that we could do differently, please let us know. Thank you again for joining us, and have a wonderful weekend. Thank you again, Dr. Carrico.
Bye-bye. Thank you.
Thank you, Dr. Carrico. Thank you, Sarah.